a case of this early plasmapheresis for hypertriglyceridemia-associated pancreatitis. So commonly, when your triglycerides are markedly elevated in thousands, it can often lead to acute pancreatitis. Um, However, usually the treatment is just treating with insulin. Certainly, plasmapheresis evidence isn't too prevalent and not recommended by any guideline currently. The case of this gentleman, he's 27-year-old, prior history of diabetes, only on metformin at home. Came to the ED initially just with blurry vision, nausea, and vomiting. He's no prior significant DKA in the past. He has no recent, infections. He's been compliant with his home metformin, no abdominal pain or alcohol consumption. Initially, his vitals were very stable, mildly hypertensive, systolic of 158. On exam, just dehydrated, had dry mucous membranes. Labs notably initially showed a pH of 7.3, bicarb was less than 10, with glucose of 645, and then pseudohyponatremia, falsely lowered by the glucose, and his lipase was normal at this time, just 73, and his A1C was 7.8. Came in diagnosed with DKA. We started him on insulin infusion and continuously try to get his glucose down. However, when they tried to draw the beta hydroxybutyrate, this kept getting thrown off. The tech, the phlebotomist, kept saying there was too much lipid and fat in the sample. So that's what kind of led us to check his lipid profile. At which point he's found to have a triglyceride of 9,563, very high at that time. And then, so about this was like day one, and he was diagnosed with this. This next day, he started having some epigastric pain as well. This wasn't really present when he came in, and then it was radiating to his back. We checked the CT because now it's concerning for pancreatitis, even though his lipase was initially normal, and it did show evidence of pancreatitis for that. We had actually had him on insulin, which is the initial therapy that's recommended for this, but given the such high levels, we ended up discussing with nephrology and then placed him under plasmapheresis. His triglyceride levels, you'll see in the course from day 2 down to day 4, went from near 9,000 and then there to less than, I believe, 800 was day 4. And it kept continuously downtrending, and then he kind of improved and his symptoms went away gradually. Overall, for this patient, I think at his follow-up, he was called him over the phone. He was doing well. Hasn't followed up with PCP, so I think he's got some history of medication noncompliance, but overall doing well after the plasmapheresis. I think the most, important thing with this was that early plasmapheresis evidence isn't too strong. A lot of times they've shown that the effectiveness plasmapheresis is limited, but these are usually limited to those later in the course. Furthermore, I think especially when the degree of triglyceride is such highly elevated as it was in this patient, early onset plasmapheresis, possibly it's not evidence-based, but could be an opportunity or something to consider.